The topic will be the spectra of immunomodulation, a case for transfusion avoidance. And this part will be done by Dr. Neil Blumberg, Professor of Pathology and Laboratory Medicine, Director of Transfusion Medicine Unit, Blood Bank and Stem Cell Storage Facility, University of Rochester Medical Center, Rochester, New York.
Okay, let's get to the beginning. Thank you for the invitation, and I'm going to address a slightly different question. Dr. Afai just elegantly spoke to the issue of transfusion, red cell transfusion efficacy. And there's not very good news there, that except for life-saving volume deficits such as exsanguinating hemorrhage and patients who can't make red cells on their own, either because of disease or iatrogenic treatments that impair marrow function, it doesn't look like we're doing a whole lot of good. And so the story I'm going to tell you begins really in the 1960s and 70s, and I'll show you a tiny bit of data from then. I was invited to talk about immunomodulation, and I should say that this is a very controversial topic for a variety of reasons, and if there's time at the end, I'll address some of those questions. But I'd like to explain that what I'm talking about here is transfusion safety. In other words, the risks associated with transfusion, and some of them have been known for the better part of more than a century, such as hemolytic transfusion reactions. But the risks that I'm going to talk about have mostly been identified in the last 40 years or so. In fact, November 1982 is when a letter appeared in the Lancet from the late Louis Burrows and Paul Tarter at Mount Sinai, suggesting that patients with colorectal cancer who were transfused had worse clinical outcomes. And ultimately, the 1980s saw the beginning of finally looking at transfusion clinical outcome studies, which started to peak in the late 1990s with a study from the Canadian ICUs and Paul Hebert and his colleagues on transfusion thresholds. And this has really changed the practice of medicine throughout the world in many ways. Let's see. So this is data from a long time ago, the late Paul Terasaki's UCLA kidney transplant registry. And for many years, it had been thought that when we transplant kidneys, transfusion was very dangerous because it caused sensitization and kidney rejection. And what Terasaki and others working in this field found was that, in fact, transfusion seemed to have a protective effect, in that if you had more transfusions, you were less likely to have your graft rejected. Obviously, the numbers today are up here, and so this is no longer an important clinical finding. And this was very controversial at the time, but it suggested that transfusions could immunomodulate patients, and they were thought to be immunosuppressive because the analogy was to the immunosuppressives at the time, such as azathioprine. And the other thing that Terasaki found was that the type of transfusions that occurred, ranging from the least purified whole blood to the most purified, such as washed or frozen cells, these are the days before leukoreduction by filtration, that in fact the least pure product, whole blood, which was transfused, strangely enough, by our standards, to patients with renal failure, actually had the most powerful immunomodulatory effect, whereas the most purified red cells had a dramatically less of an effect. And so this has been known now for about a part of 40 or 50 years. And what Tarter and Burrows, the surgeons at Mount Sinai, found was that if they looked at a cohort of patients, and this is not a randomized trial, that in fact, the patients who were transfused had many more frequent and earlier recurrences. And of course, this was very counterintuitive at the time because very little was known about the effect of transfusion on cellular immunity, and almost nothing was known about the effect of cellular immunity on cancer recurrence. We now know that immunotherapies are in fact the most powerful therapies we have for treatment of some cancers. Various types of immunotherapies, including CAR T cells, are now showing dramatic ability to cure diseases, even at the end stage of diseases like leukemia and non-Hodgkin's lymphoma. But none of this was known at the time. So this was really quite counterintuitive. And we don't have a definitive answer yet, but I'll show you some additional data later. So Tarter went on, he was a resident at the time, to study infection. He reasoned that if transfusions were immunosuppressive for the and that was good for kidney transplant and bad for cancer, that it might be bad for surgical infections. And he published some data. And this is a study from Lillian Burrows at Louisville. She was a trauma surgeon there. And what she showed was that there was one of the most dramatic associations between a therapy or a treatment or a habit such as smoking. Smoking in lung cancer is about a 20-fold increase. Smoking in heart disease, about a 10-fold increase. And what you can see is there's a dose-response effect between the number of units transfused to trauma patients and the incidence of patients with infectious complications. Now, obviously, this is not a randomized trial. It could be confounding, but when you have an almost 10-fold increase in something, it's very unlikely to be confounding. And in fact, in animal models, it was shown that transfusions do, in fact, impair host defenses, as Tarter hypothesized, against postoperative infections. And this is a more recent example of a cohort study in the Annals of Thoracic Surgery, just showing an almost 10-fold increase in pneumonia in patients undergoing heart surgery. So what do we make of this? Well, you could argue that this is just an epidemiologic association, but in fact we now have a lot of randomized trials, better part of 10 to 15, using leukoreduction, which removes most of the white cells and most of the platelets from transfused red cells. And this is just some of the studies. And this is a meta-analysis that just shows that if you look at leukoreduction, the studies clearly show a decrease. There's a lot of variation for various reasons, but that leukoreduction reduces postoperative infections by 30 to 40%. It doesn't make them vanishingly rare, but there is some benefit, and that's why universal leukoreduction should be used. There have been a fair number of randomized trials, including those in cardiac surgery, and those in cardiac surgery have shown a halving. These were done in the Netherlands, in Amsterdam, and in Leiden, and leukoreduction reduced the mortality rate in cardiac surgery, presumably from multi-organ failure, mostly because that's what the cause of death often is postoperatively, especially in patients with infections. And so literally a doubling of risk when you give non-leukoreduced transfusions. So most cardiac surgeons and cardiac anesthesiologists will absolutely insist that their transfusion service give leukoreduced blood. And as a side note, while there are 3 separate advisory committees that have asked the FDA to implement universal leukoreduction, the FDA in the United States has taken no action. The AABB has not recommended leukoreduced transfusions, even in cardiac surgery. And so this has become a political football, even though universal leukoreduction was introduced in Canada, the United Kingdom, and France almost a quarter of a century ago. And this is a rather sad story historically. So leukoreduction shows that the association between transfusion of allogeneic blood and postoperative infection and mortality is causal. It's not an association. Transfusion is causing these infections, causing these deaths. And in fact, there are data, which I'll show you a little bit, that autologous transfusion protects against these. These effects are not seen with autologous transfusion of various sorts, whether it be salvage, pre-deposit, autologous transfusion, or normal volemic hemodilution. So we know this is an immunologic effect. It's prevented by leukoreduction to some extent, and actually prevented almost probably to a larger extent by use of autologous transfusion. And in a meta-analysis that was done some years later, I'll show you restrictive transfusion strategies seem to have similar benefits to leukoreduction or autologous transfusion. So immunomodulation is real, and it can be modified but not completely obliterated, so to speak, by leukoreduction, and it can be dramatically altered by autologous transfusion or avoiding transfusion. One of the interesting things about leukoreduction is it's also, at least in our hands, reduced the incidence of acute lung injury to almost zero in our institution. It's also dramatically affected the amount of the number of patients who were diagnosed with congestive heart failure, or as blood bankers like to call it, circulatory overload. I don't know why we needed to come up with a new name for something that was well established, but that's also reduced. And so we have a lot of benefits of leukoreduction if a patient is willing to accept transfusion and we use appropriate criteria. There are many, many advantages to leukoreduction to make transfusions safer. So these are the autologous transfusion data. These are some randomized studies. Marcus Heiss from what was then West Germany in the 1980s. And then after Germany was unified and he published the full data set, showed that autologous transfusion in a variety of settings, Heiss's was in colorectal cancer surgery, improved clinical outcomes in terms of cancer recurrence, but also had a striking benefit in terms of nosocomial infection, postoperative infection, reducing it by almost half. So autologous transfusion, and these are not all pre-deposit autologous. I believe Newman was a hemodilution, normal hemodilution, and one of these studies was salvage. So there are a variety of autologous techniques, some of which are acceptable to all patients, can be used to reduce the bad outcomes after surgical interventions. And this is restrictive transfusion in the upper GI bleeding, a study from Barcelona, Villanueva and colleagues, just showing that the restrictive transfusion strategy, even in upper GI bleeding, saved lives. The overall survival in this randomized trial was twice what the overall death rate was twice in the liberal strategy versus the restrictive strategy. And in fact, you can see why some of the, contrary to the arguments that transfusion is needed to prevent heart attacks, myocardial infarction, there were actually no heart attacks in the restrictive group, but 8 in the liberal group. So as Dr. Rafai was showing you, it may be that impairing the oxygen delivery and increasing thrombosis, which is another effect of allogeneic transfusion, increased thrombosis, it actually makes things worse in terms of cardiovascular outcomes. And finally, this is restrictive transfusions. This is a meta-analysis, part of a meta-analysis that appeared in JAMA and is in a textbook chapter that I'd be happy to send to anybody who sends me an email. We've written a chapter on transfusion immunomodulation for a textbook. It's probably the only textbook chapter that treats immunomodulation in the broadest sense, and I'm happy to provide the latest edition of that. And as you can see, restrictive transfusion also reduces postoperative infection, in this case in orthopedic patients. So the question of what the effect of transfusion is on cancer when it is established is still an open question, but I think we know that it clearly has effects on some patients. This is a study asking the question, does cancer occur more frequently? Are malignancies found more frequently in patients who are transfused? And they looked at patients 5 years later after transfusion. Clearly in this study, there was a higher incidence of certain tumors. And the interesting thing to me, as somebody who's interested in the immunobiology of transfusion, is the cancers where there's been a strong association between recurrence at the time of cancer surgery, such as colorectal cancer, renal cancer, the more immunologically manipulable cancers are also higher, suggesting an immunological source for at least some of these tumors, that these patients had been immunomodulated and made them more vulnerable to developing cancer in the future. And if so, that's not good news, obviously. We don't want to be increasing the risk of patients having cancer. And I think this is our own data, and it's in acute leukemia, acute myelogenous leukemia. And we have found that patients who have pretty good risk leukemia, younger patients, who are given wash transfusions, another modality for reducing immunomodulation, have strikingly better survival than other patients treated at centers that do not use wash transfusions. So this is based partially on a randomized trial and partially on observational data, but we think this is clear evidence that, in fact, transfusions do immunomodulate patients and increase the risk of recurrence of both leukemia and solid tumors in some cases, and may, in fact, be modifiable by such modalities as washing. So this is just a complex model that Ken Remy and a couple of other pediatric immunologists and intensivists put together for publication in Transfusion a few years ago. And it shows some of the theories about how transfusion both increases immune suppression, but also increases inflammation. And we could call this immunodysregulation. So allogeneic transfusion, but not autologous transfusion, seems to be a very powerful and negative influence on clinical outcomes. So in summary, transfusions predispose to postoperative infection, sepsis probably, cancer recurrence, lung injury, inflammation, multi-organ failure, and clearly thrombosis, since there's a randomized trial showing allogeneic transfusion increases thrombosis in some patients. And that by using restrictive or bloodless technology or approaches, or autologous transfusion as part of bloodless medicine, are going to be associated based on randomized trials with reduced morbidity and mortality. And this is one of the reasons that Jehovah's Witnesses, in studies by Dick Spence and others many years ago, witnesses who do not want transfusion as part of their care actually have better clinical outcomes. And Aryeh Shander, pioneering his work at Inglewood Hospital, showed that when his witness patients were treated with their multimodality approach, they also had better outcomes. And in fact, their open heart surgery program had the lowest mortality and lowest best clinical outcomes of all the programs in New Jersey when it was implemented. We know that for patients who will accept transfusions, that we can modify some of these unfortunate effects by leukoreduction and by restrictive transfusion. And the work that I've showed you that's come from our center has been the work of many, many people, including Dr. Rafai, who just spoke, but I'd like to particularly acknowledge my co-leader of our research group, Dr. Joanna M, who is also my wife and has made an enormous impact on the work that we've done. Anyway, I'll stop there. Thank you very much for your patience.